That's right, Dr. Eric Johnson. And so this is the impressive part. He is a child and adolescent psychiatrist and the medical director of psychiatry at St. Luke's in Cedar Rapids. And so he's going to talk about psychiatry with adolescents and how that relates to, well, you'll tell us. You'll tell us. So welcome. And feel free to move up closer so you can see the slides really well. And if you want to, or get up during whatever you want to do. Okay, bye.
Thank you, John.
One more thing, we will hand out the microphones to those that want to ask questions. So raise your hand or say you need the microphone, so because we're recording this, and that way the questions will be on the recording. So thanks a lot.
Thank you, John. It's very reassuring to see happy, smiling, familiar faces. I have not practiced the steps of both referring to my slides and advancing them. We'll see how I do. I wanted to thank the Reconciling in Christ team here at Holy Trinity for inviting me. I was at first wondered, why me? What can I offer? I've enjoyed the process of preparing for this, and I'll hopefully explain why. I want to thank the RIC for doing this process in a careful, thoughtful way that's allowed for discernment. It doesn't feel rushed, and I very much appreciate that. I think it's good for our congregation to have time to sort of digest things as they come. As we go through tonight, we're a familiar group. I don't mind if I read that you want to spend some more time on a topic, we can. If I see glazed look like I need to get moving, then we'll go through it. If I just went and we didn't stop once and talk, it would be about 50 minutes, just to give you an idea. And I want to leave some time for questions, so if I feel we're stuck too long on a topic, I might move us along too. No, not from me at least. No medical advice will be given today. As I like to say, I am a psychiatrist, I am not your psychiatrist. And obviously I don't speak on behalf of my employer or any of my professional societies. This is me. The talk is about the mental health care of LGBTQ plus youth. Most of the discussion, most of what I found tends to be around the hot button topic of gender diverse youth. Lesbian and gay youth have similar struggles. Most of the information we talk about can be applied to that group, those groups as well. A few months ago, and many of us were here, I thought Clay did an outstanding job describing that the research does not show a definitive, clear-cut cause and effect link between gender-affirming care, which we're going to talk about in detail, and improved outcomes in measures of depression or suicidal ideation in these young people. The gold standard in medicine is the randomized controlled trial. We have RCT for antibiotics, heart medicines, all kinds of health problems, but this level of evidence is still being built in terms of gender-affirming care. International, this isn't just America, but international reviews have pointed out that much of our data is low certainty or low quality because we can't easily run the type of studies of controlled trials that we'd like to see. However, low certainty is not the same as no evidence. What we do see over and over again in large-scale studies is that when these youth are supported, their mental health improves. So we're in a difficult clinical position. In the absence of perfect data, do we wait for better data or accept the risks of intervening with the data that we have? And like Clay mentioned correctly, we really don't understand much in the way of medical or psychological reasons for children and adolescents who don't fall into the traditional gender binary. And we certainly don't agree in the medical community what we should do for them. But the good news is, I think I'll present to you, I hope to present, that it's easy to provide what might be the best treatment of all, and it doesn't require a medical degree. All right, a little bit about my role. I'm trained in psychiatry, I'm board certified in psychiatry, and then I fellowship trained in child and adolescent psychiatry at University of Iowa. At University of Iowa and most Midwest programs, it's an extremely biological training for psychiatry. And what I mean by that is expert training on proposed biological mechanisms and biological treatments for major psychiatric conditions like major depression, schizophrenia, bipolar disorder, ADHD. My training in psychotherapy or extended long-term counseling is less. I didn't get as much training in that as a professional therapist would or a psychologist would. I have no specific training in the specific care of LGBTQ plus patients, but I have cared for many such patients. I don't have experience in things that psychiatrists don't get involved in usually, like prescribing hormones or hormone blockers, and I certainly don't do surgery. So I am not a subject matter expert on this in this topic. I had to prepare by doing my own research. This isn't all just my knowledge. Psychiatric care of LGBTQ plus young people is a relatively new subspecialty. I don't recall much education at all in terms of this kind of healthcare 18 to 20 years ago when I was in residency or fellowship. And I frankly find it intimidating because these issues are extremely polarizing. Major organizations of experts disagree, so what am I to do in Cedar Rapids, Iowa, if the experts can't give me clear-cut guidelines? So today's talk will also not include much on medications. There are no FDA-approved psychiatric medications for conditions specific to LGBTQ+, such as gender dysphoria. But we do use medications in these young people for concurrent or what we call comorbid mental health conditions, which we'll discuss a little bit. Medication can be a tool, but for these young people, environmental and support, that's going to be the theme today. They are the mainstay treatments. I am also predominantly hospital-based, so I work with youth in acute crisis and with more severe symptoms. They come to the hospital when outpatient treatments and safety nets fail. Just to give you an idea, people often wonder, what is inpatient mental health psychiatry? Why do they come in? Usually for suicidal ideation, self-harming behavior, suicide attempts, extreme behaviors where there's dangerousness to the person or loved ones, psychosis, or if they're court-ordered, which is also common. And then just a brief graphic. Sometimes people aren't real clear on the difference between psychiatry, psychology, therapy. This is obviously just a snapshot. We all work together. It's multidisciplinary care. Psychiatry are medical physicians trained in all branches of medicine, just like any other physician. Then we specialize in mental health. And psychologists are specifically trained to provide assessment, diagnosis, and treatment. And then in the United States, psychologists also do testing, IQ testing, neuropsychological testing, a whole battery of specialty testing they can do. And then master's level therapists are often social workers, but not always. And they train in specifically delivering high quality evidence-based psychotherapy. There's lots of different types. Okay, moving ahead. Childhood brain development. I thought we should get started on the process we all went through, our kids or grandkids went through. Everyone in this room is of a certain age, and so it's maybe been a while since adolescence for us. Google AI, yes, I used it a little bit, suggests that I use a construction metaphor when we talk about brain development. Neuroscientists would probably struggle with this because it's a crude description for brain development, but I think it will be fine for our purposes. The ages 0 to 3, this is what we can refer to as pouring the foundation. Rapid neural development and sensory mapping. Of course, you're learning how to speak. You're learning how to express yourself as a toddler. The brain grows rapidly and gets to about 80% of its adult size. That's why little ones have big heads for their bodies. You can't see the final house yet in our construction metaphor, but the ground is being prepared for everything that follows. Next, 3 to 6, finalizing the blueprint. Architect draws the lines, the rooms are labeled, the internal map of who that child is, including gender, boy, girl, neither, both, is finalized. Even if the exterior walls haven't gone up, the design is already set. So research shows that core gender identity consolidates in this time block. It's probably, we don't know this, it's probably a complex interaction of biological predisposition, not everything, and then also environmental influences are felt to play a role on gender identity. Next, 6 to 12, the interior design phase. It gets a little unusual here, but just go with it. This is the period of social inspection. This is where it's traditionally called the latency period by developmental psychologists. It's quiet, pre-puberty, of course, but it's incredibly important. The child is deciding whether to show their true identity to the world, either being themselves or hiding and building a false front. Children test their identity against social norms, peers, and authority figures. They're looking to see if the community passes them through inspection and approves of their blueprint. So in the upcoming chaos of puberty, a false front would be the first to collapse in our metaphor. So when we see a teenager struggling, we have to realize they aren't remodeling their identity on a whim at that age. They're trying to build a life that fits that blueprint that was drawn years before they ever reached middle school. I wanted to make a comment because it often comes up. You know, what about tomboys? We used to have tomboys, and now are they all just transgender? Someone raised their hand. You're owning that one? Exactly. Yeah, I mean, tomboys still exist. They haven't gone away. I don't know of a non-pejorative term for biological males who prefer feminine activities, but it's the opposite of tomboys. These terms refer to gender expression, how you, the activities you enjoy, the clothing you wear, how you look, but it's not your gender identity. These people, these young people still exist, but it's different than somebody who their gender identity doesn't match their biological sex. Myth. So is this whole transgender issue just a phase or a trend? Well, as I mentioned, research shows that children often do have a stable sense of their gender identity between the ages of 3 and 6. We'll talk about some youth explore their identity and may change over time, but the studies show that rarely do kids grow out of it after reaching puberty. Okay, and now we reach adolescence. This is considered the storm in our construction. You know, adolescence, what a strange time developmentally. It's a fantastic construction project going on. When puberty hits, the emotional part of the brain is running at full speed. The mature logic part, however, is not there. This is high-speed, high-stakes construction. With our metaphor, think scaffolding everywhere. It's a mess. It's very vulnerable to stress. As the child physically develops, if the physical house that's changing and being built contradicts their original blueprint from a young age, the structure begins to fail. So this stress fracture in our metaphor would be akin to gender dysphoria. At this point, the brain is full-sized, neuronal connections are abundant, even excessive. Another metaphor here would be an overgrown garden needing to be pruned. And indeed, neuroscientists refer to what happens in adolescence as pruning. Excessive neuronal connections are trimmed and the whole brain becomes more efficient. And then we'll now borrow from a driving analogy. The brakes of our brains, the part that makes us very human, the prefrontal cortex, impulse control, weighing risks versus rewards, long-term planning. Adolescents aren't there yet. That part is not yet developed, and that develops well into what we would consider young adulthood. But the limbic system, the old part of our brain, think gas pedal, emotional and reward center is formed much earlier. So all gas and no brakes. That's teenage years, right? You all may remember from your school years Erik Erikson, the famous psychologist, in his stages of development. He coined the phrase identity crisis because of this part of development. He taught us that adolescents are particularly vulnerable to feelings of shame when their specific developmental task of identity formation is not going well. Their whole question is, who am I? So teens must integrate their values, their beliefs, and their identities. And if we aren't able to explore this safely, then comes role confusion, which is a deep sense of being lost or fractured. In this age range, social rejection, I mean, you know how hard it is for teenagers to deal with rejection. None of us like rejection, but teenagers, it is everything to them. And social rejection can feel just like a physical threat at this point. So feelings of shame plus social rejection are unfortunately the seeds that we think depression, anxiety, poor or maladaptive coping all stem from. Fortunately, there are protective factors, supportive family acceptance, inclusion in community, affirmation of identity, and access to supportive adults. Everybody good with those concepts? Sound good so far? Thanks to Pastor Tim for encouraging me to make my font bigger, by the way. He said it didn't show up very well on the first run, so thank you. Oh, it didn't go? Unfortunately, my animation didn't go, so I'm going to hide it because it gives away my answer. So, I'll show you that slide in a second. But are social media and peer groups making kids trans? Is TikTok making kids trans? This is the social contagion theory, that peer groups and social media are recruiting or influencing children into these identities. I think any of us would at least wonder, is there something in pop culture that is adding to this? And that's okay, I think, to admit. I've thought it, but I also know I don't know what I don't know. The available data suggests that this is not the case, that there is increasing prevalence. Prevalence in medicine is the number of people who have the, I hesitate to say condition, but are positive for that trait. The best estimates amongst high school students, this is from the Trevor Project, which is a resource that you can all find pretty easily online, is that high school students identifying as LGBTQ+, 10 years ago, 2015, 11 years ago, was around 7 to 8%, and then now is anywhere from 25 to 28%. That's all of LGBTQ+. Specifically gender diverse, that's transgender or non-binary are the two biggest categories, has increased from around 1.5 to 2% 11 years ago up to 3.3% in recent surveys. Similarly, WPATH, which is an organization we'll talk about later, their survey suggests a rate of about 1.2 to 2.7%. And these are higher than adult rates. These are self-report, exactly. These are surveys, exactly. Yes, I believe that was specifically high school. The WPATH, I don't know if that was that specific age range. Adult rates are typically, there's no consistent data, it's typically less than 1% in adult people identifying as transgender. It really depends on whether this survey is based on people referred for care, as in showing up at a therapist's office or a doctor's office, or self-report on a survey. The numbers are going to change. So as society becomes more affirming, the perceived and actual risk of young people coming out decreases. So in general, creating a world in which it's safe to feel counted and be counted. Youth may feel safer exploring their identity when they aren't facing immediate expulsion from their families or their social circles. So as well, the internet and social media have also provided a vocabulary, non-binary, gender fluid, which we didn't really have in the past. So a person who has an internal experience but can't name it, how do you then identify? So this increase in vocabulary has perhaps helped young people match to their internal blueprint. So we do see a higher prevalence of, you'll read, but what about, we see a higher prevalence amongst gender diverse youth, a higher prevalence of autism spectrum disorder. And this doesn't mean that they aren't trans or they're not non-binary. It means their identity is viewed through a different lens than most of us understand, a neurodivergent lens. Similarly, young people with a history of abuse or trauma tend to have a higher rate of non-conforming gender identity. So we do aim in mental health to distinguish what is persistent gender dysphoria from identity confusion, which can relate to a lot of different clinical factors. But the initial treatments, unconditional support, a non-anxious presence, and a safe community, they're the same regardless.
Eric, maybe it would be good to define what gender dysphoria is.
Yes, and it will be part of, I probably could have adjusted the order, but we will talk about gender dysphoria. Thank you. I think it's also essential to acknowledge the shifting demographics of gender divergence. It's not yet fully understood. Historically, gender dysphoria, and I acknowledge we could have talked about that earlier, was more common in biological males with childhood onset that persisted into adolescence. The current rise, we believe, is predominantly amongst biological females with adolescent onset. We don't know why, but that brought out the very controversial term rapid onset gender dysphoria. Maybe you've heard that because historically gender dysphoria was not felt to be a sudden onset. It was there since early childhood. And there has been a shifting demographic that can't be fully described. I will say there is no such diagnosis of rapid onset gender dysphoria in my field or other professional mental health fields. It's more of a, I believe, I'd call it a pop culture term. So again, we don't have good long-term data on this newer demographic because it's been noticed just within the last 6 years. So I do want to address a very real concern. What if we're wrong? How do we know if all these adolescents really are transgender? Two things can be true at once. For the vast majority of them, gender identity is a fundamental truth. And for a smaller subset, their sense of identity might be complicated by other factors or other mental health challenges. Can't both those things be true? In other words, some individuals who identify as trans are indeed trans and may someday benefit from professional, medical, or even surgical transition. Some individuals have other mental health conditions which also contribute to identity confusion, and maybe they won't benefit from transition. There's no definitive yes or no answer whether we're wrong. Both things can be true. We don't have to be certain of the final destination to be certain of how to treat the child today, though. If they're confused, the worst thing we can do is reject them or shame them. That only adds more trauma. So I had to take away the photo for the following interactive part of my talk. I want to compare this problem, and I use the word problem in quotes because Clay's video brought up a good point that folks dealing with any of these types of issues get a little frustrated by it being called a problem or a disorder. So I want to be respectful of that. And in general, that is my goal. If I say something that may not be the most ideal, most people I work with are patient because they know you're trying. That's the important. You don't have to be perfect. So they want to see effort, and I can do that. So there was a historical problem in 1900. It affected about 2% of the population. 2%. It was a major problem which needed to be corrected because there were harsh punishments oftentimes for individuals with this problem. It was a bad habit at the very least. At the worst, it was a sign of moral or mental deficiency, even a mark of criminal behavior. Society eventually shifted and learned to accept this problem, and when we stopped punishing and correcting it, the prevalence increased and eventually plateaued. Going from 2%, it's held steady at 12% for the last 70 or so years. Any guesses on what this problem was? We've got a left-handed guess. Anything else? Big time problem. Can be an issue. Chris has got it. It's left-handedness. Well done. It used to be a sign of great moral deprivation, and then we fixed it, and the prevalence rate went from 2% to 12%. So just as the number of left-handed people rose once it was no longer punished, more youth we feel feel safe to share their identity today because of growing acceptance. So visibility is considered a sign of safety, not a contagion.
I'm going to say my mother and my dad are both left-handed.
I wonder if they, but they,
That was my problem.
now Fred, your parents probably weren't around in 1900.
No, they were in the 20s.
20s, okay. So I did not know this. I learned this. I learned that apparently there was a significant, what they call neurological tax to forcing a left-handed child to switch back then. It required the brain to work against its natural wiring. This led to increased rates of stuttering, learning disabilities, and anxiety. And I think we can hypothesize that forcing a child to switch their gender identity creates a minority stress, which we're going to talk about in the next slide. The brain is forced to spend energy performing a role that doesn't fit its internal blueprint, leaving no resources for healthy development or emotional regulation. So when we ask a transgender youth to just be a tomboy or wait until you're older to use your name, we might be imposing that same neurological tax. Everybody good so far? Now we're getting to mental health in LGBTQ plus youth, definitely a population at risk. All teens struggle. It is the most tumultuous time of our lives. This trend actually appears to be worsening as well. Mental health of teens in general is not better than it was a generation ago. But the baseline for LGBTQ plus youth is higher. They face significantly higher mental health burdens than their cisgender heterosexual peers, in particular amongst the LGBTQ plus youth, specifically transgender and non-binary adolescents. All these resources, you probably can't read them real well, but Trevor Project, CDC, American Psychiatric Association, they all have similar stats from their surveys. Rates of depression, and these numbers are rather astounding, actually. It's shocking. In a survey, cisgender and heterosexual peers have rates as high as 31% of some symptoms of depression, while in LGBTQ plus youth, persistent feelings of sadness or hopelessness, 54 to 66%. Anxiety disorders. In cisgender and heterosexual peers, symptoms consistent with generalized anxiety as high as 42% in the general population. LGBTQ plus youth, 68% of generalized anxiety. Those are staggering numbers. But then we get to safety. In the last 12 months, the percentage of LGBTQ plus youth who have seriously considered suicide, 41 to 45%, versus 13% in cisgender heterosexual peers. Attempted suicide. The rate is as high as 6% in cisgender heterosexual peers, 12 to 20% in LGBTQ plus youth. So suicide attempts are significantly higher in transgender and non-binary youth, possibly up to 4 times higher. Really tragic numbers. And too high across the board, let alone in the special population. There's considered to be an access gap, access to care. 50% of LGBTQ plus youth who wanted mental health care in the last year were unable to get it. Fear of being outed, if they're not ready for that. Fear of not being treated seriously. So 50% not getting care is tragic as well. I'll share a personal story as it pertains to accessing care. So as a child and adolescent psychiatrist, but also obviously white, male, 50-something, cisgender, heterosexual. They don't know that, but they might make assumptions. I'm sure they make a lot of assumptions about who they see professionally. I'm probably everything they fear when it comes to accessing care. But when I do simple things like ask them what name they want to be called and what their pronouns are, pretty easy to do, by the way, I believe they realize I mean them no harm, and they can be who they are. You can just see the tension leave their body. It's one of the most simple things I can do, that we can all do, and you can just tell that it's okay, at least I'm safe in this room. They don't ask me if I believe them. They don't ask me what my politics are. They just want to know they're safe, and that's, again, a pretty easy thing to offer. So, and if your reaction to these stats I shared is, well, the Trevor Project is an advocacy group, and they are. They provide the most granular data on this population, but their findings are consistently mirrored by the CDC, a federal agency, as well as the American Psychiatric Association. So why is this? Why so much higher rates of depression, anxiety, and suicidality? Are they broken? Is something wrong with them? What do you think? No, right? Well, the science says no. Brian West's question, I'll pause that for your question.
You think it's because the nuclear family's disappearing? You don't have two parents in the household and you don't have the support of a parent?
I don't know if there's any specific data, so I can't give you a professional answer. I can tell you anecdotally that that's not a accepted explanation. So I don't think we can definitively state that there's any science to back that up. I think it's always fair to make a list of possible reasons and analyze those, but that wouldn't be an accepted reason. My rhetorical question is something broken in these young people. The science says no. These disparities in depression, anxiety, and suicidal ideation, it's based on external factors, which we'll talk about next. The why, minority stress. Early 2000s, the minority stress model is still being used as the leading framework to explain why marginalized groups, particularly LGBTQ plus individuals, do experience higher rates of mental health difficulties. The core premise is that mental health challenges, it's not inherent to being an LGBTQ plus person, but instead it's caused by a stressful and sometimes hostile social environment. External stigma, discrimination, and not the identity itself, therefore drives the mental health struggles. Think of it like a tax on the brain. Most kids deal with normal stressors, tests, sports, peers, parents. LGBTQ plus youth pay an additional stress tax just for existing in spaces where they're not sure they're safe. Over time, this chronic stress leads to the anxiety and depression we saw on the previous slide. In mental health, a big part of our biological thinking is that chronic cumulative stress contributes to mental health decline. Biologically, it could be because of the constant wash of stress hormones, cortisol and adrenaline, and the effects that has long term. The minority stress model divides stress into two different types: external stresses, the obvious ones like bullying, violence, discrimination, feeling excluded, and then internal stresses, which we can think of as an echo of what's going on around them, and then what happens inside. A state of hypervigilance, one of my favorite terms because it really nicely describes this constant state of being on edge and fearful of what's going on around you. Is it safe here? Expectation of rejection. If you go through every day expecting people to reject you or treat you poorly, that takes a toll. Having to hide one's own identity and internalize stigma. So, bold print, I'll say it again just to make sure it's all clear. LGBTQ plus youth have higher rates of mental health concerns, which are responses to the environments they navigate. So isn't everyone stressed these days? Well, yes, adolescence is universally stressful, but minority stress is additive. Take the baseline stress of being a 14-year-old these days, add to that stress that peers don't have to navigate. So it's chronic, it never turns off, it's constantly there. The power of community. So what is a protective factor? In medicine, a protective factor is exactly what you think. It's any attribute or exposure that reduces the likelihood of a negative outcome. So for LGBTQ plus youth, community support is absolutely a protective factor. When a youth moves from an environment of negativity or even neutrality, where they must remain hypervigilant, to an environment of active affirmation, the brain's stress response, or what we can call the fight or flight system, can begin to downregulate. So it's not just kindness, but it's actually a biological buffer against the minority stress we discussed. So those of us working in mental health, we can prescribe therapy and prescribe medications, but we can't provide a supportive community. And then I want to introduce the concept of social determinants of health. This is a World Health Organization. The term's been around for eons, but the World Health Organization has really begun to highlight it. And it's one that I never even heard this term in medical school or training, but it's become a very important topic in the last decade because we realize all the non-medical reasons for negatively affecting somebody's health, or can be positive. So these are the non-medical environmental conditions which affect health. It's where we're born, where we live, where we learn, where we work, play, worship, age, a person's access to power, money, and resources. They all obviously significantly affect health, functioning, and quality of life. As you would imagine in psychiatry, or more broadly mental health, social determinants of health play a huge role, perhaps bigger than any other area of medicine. Church couldn't be a significant part of somebody's social determinants of health. There's a concept I learned about called the faith paradox, and it will make sense to you. Churches historically in mental health are a gold standard protective factor against depression and suicide. Churches and faith can give our lives meaning and purpose, offer us community, offer us structure and routine. However, if LGBTQ plus youth feel rejection and a lack of safety at church, it actually is associated with risk of increasing depression and suicidal ideation. So that sets up what's called the internalized religious conflict. It's psychological distress when somebody's deeply held spiritual or religious beliefs clash with their identity. One of the most important things I think we're going to discuss today is the power of one adult. LGBTQ plus youth with at least one accepting adult are significantly less likely to have had a suicide attempt. One adult, potentially up to 40% less likely to have had a suicide attempt. That's pretty significant. I hinted at that early on when I said it doesn't take a medical degree to be a powerful form of treatment. Here we are. In case you are wondering if you can be the one adult, yes, you can. Doesn't have to be a parent, therapist, or doctor. It can be a teacher, a neighbor, a coach, a member of the faith community. We'll talk more specifically, but how do you do it in general, where you listen more than you talk, you validate even if you don't agree or understand, and stay in the conversation even if it's awkward. That's kind of an intro. I was going to say, because it's not animating, I'm giving away my answers, but you won't be able to read it anyway, because, so I'll read it for you. So keep in mind, that 40% reduction in suicide risk, it's not a medicine, it's not a 10-week therapy program, it's the presence of one adult. My intention was to have a kind of group discussion, and we still will, about how you can be the one adult. Some of the categories offered by the Trevor Project include identity affirmation. Any thoughts or ideas, and there's crossover in between these categories, but how could you be the one adult in terms of identity affirmation? Any thoughts? Yell them out and I'll repeat them. Yeah, use the name they'd like. Anything else? Their pronouns, absolutely. Anything else people can think of without looking at my answers?
I have something really specific because it just came up in my class today.
Yeah.
Because I teach a class where teachers are thinking about these things.
Yeah.
And somebody said, you know, I had a little boy pick up the book Pinkalicious.
Okay.
And I almost like gave a side eye and I was like, what a great choice. I love that book. And like examining their biases so that when those things come up, they don't have to pause.
Right.
But just be like, what a great book. Love that book.
Yeah. Great example, and that's one I think that you could plug into multiple categories here. Affirming what they were. That comes up another one, but that's a great one. So I think we can talk about these collectively, you're right. Letting them wear or affirming they'll wear what they wear, but you can affirm it. Also, one suggestion was expressing that you're proud of them for being bold or coming out. Open communication, any specific ideas? I had listen without judgment. Ask what you need, how can I support you? Environmental safety. Any thoughts? Well, that's a very practical, if someone's struggling, you have to keep a safe home, you're right. Mm-hmm. Elsa?
Oh, it's on, is it? Yeah.
Yes.
With open communication, if I love asking questions, but I am learning over and over again that certain questions feel safer for a person you don't know at first, and then later on find out which questions will be continue to be safer. And I think that that is so important for any child of any age. One of the worst experiences I had years ago was when somebody came and wanted to sell, what was it called? A vacuum cleaner. And I was about 60 years old at that time, and that person treated me like I was a kindergartner. But I said then afterwards to my children and to my husband, I wouldn't even treat them that way.
Yeah.
When they were a kindergartner.
Absolutely. People definitely feed off of how you interact with them, and it affects every part of communication. Absolutely. Environmental safety, being publicly supportive, not acting like you're ashamed to be near the person that you care about. The obvious things, stopping bullying if you see it, standing up for them, having their back, advocate for inclusive policies could be. There's no right or wrong answer here on how to be that one adult. Connecting them with resources, finding affirming care for them if it's appropriate, finding a supportive church family for them, and then relational stability, which we've hit many of these topics, being consistent. I like this one, including in family activities as who they are, as their full self, not expecting them to be different or changed in activities. One I saw time and time again is also educating yourself, not expecting them to have the burden of teaching you everything. That's a good one for us as well. Fred.
I was wondering what role schools can play in, because when you have a classroom of 30 or 40 people, what role can the teachers or the principals, or how do they handle these issues when it becomes a bullying issue?
Yeah, and I'd open, I'll share my thoughts, and then I'd open it up to any other educators in the room who might have thoughts. It's a challenging concept because different schools handle this much differently. Some are really good at it, and some schools I constantly hear about how bad the bullying problem is there. Obviously, every young person needs to be safe at school. You're always going to have young people mistreating each other, but there's got to be some clear boundaries. I don't know how schools do it. It's challenging because for every time they provide education on a topic, they probably have then 5 parents, 10 parents calling to yell at them about, keep this out of my child's education. Lisa, would you agree with that? I don't know how to do it. Do you have anything you want to add?
Would be at the topic of a whole lot more. I mean, it's just things that we used to take for granted. There was a time when the state of Iowa sent out a set of books for classroom use that included families with same-gender parents, that now teachers are scared to death to have those same books in their classrooms. Things have changed a lot.
Yeah. Fred, I appreciate the question because school is, we all have had our jobs, our full-time jobs. School is the full-time job for these children. They're there a significant part of the day, and it can be a really toxic environment. School's rough for everyone, but it can be real toxic for LGBTQ plus youth. Lynn?
What we taught our kids was to find that one teacher that you feel safe with and bond with that teacher and feel safe with that teacher. And both of our kids chose the same teacher
Yeah?
at our local junior high. It's middle school now, but at that time it was junior high. And that teacher saved our kids' lives.
That's awesome.
Literally.
That teacher obviously took the role of being that one adult.
She did.
Yeah.
She called me on a
Seriously.
Sunday morning. My daughter had sent her a suicide note.
Mm.
So she saved our kids.
Yep. She's a blessing. All right. Thanks for the input on these. So that was the role of community. I should encapsulate a little bit that being that accepting adult, it's not complicated. Don't overthink it. It's the relief of a person not having to be hypervigilant. When you use the preferred name or simply show them that they're a valued part of this congregation, for instance, we think you're effectively lowering their cortisol, stress hormones, and you're helping their brain kind of out of that combat mode and into a state where they can grow. The role of family now, the family is the base camp. So for an adolescent, the home is either the primary source of safety or the primary source of stress. And I really I can empathize with parents in this situation of raising a child who is LGBTQ+. There's no easy answers. It's tough. A concept that I'm going to talk about, I'll wait on that because I have some thoughts on how challenging that can be. But acceptance is definitely a spectrum. It doesn't require perfect understanding right away. It doesn't require parents to have a total shift in their theology overnight. Helping parents gradually move from rejecting behaviors or trying to change the child or exclude them to supportive behaviors like sticking up for them, talking about their identity, that's the goal here. Here's a bold print. Family support remains the single greatest predictor of the children's health. That's across the board, but particularly for LGBTQ plus youth. High levels of family support can help out cancel some of the negative effects of bullying at school or in the community. Here's another one of those staggering statistics. LGBTQ plus youth with high levels of family rejection are 8.4 times more likely to have attempted suicide. 8.4 times more likely because of family rejection. That is what I would consider a staggering statistic. Parents often will look to their faith community for cues on how to treat their child. A supportive church helps parents be what their children need. But we also know that many parents struggle because they might feel they have to choose between their faith and their child. And this is where community comes in. So when the family feels supported by their church, they're better equipped to provide what their child needs. The role of the family, perfection is not required. We have a comment question.
Maybe you'll get into this a little bit later on, so if I'm jumping the gun, please tell me. But in terms of parents who might be wanting to be supportive of their child as an adolescent, up until the point of talking about physical surgery, where does that line draw? Because there are parents we know what we're aware of, at least in terms of what we've read, who are accused of being haters when they draw the line at that point, right?
Yeah.
Is there any further insight you've gained into that aspect of this that is helpful to discern between those or not?
Unfortunately, only that there aren't easy answers because that's some families will be particularly ready for that step and supportive, and some will really, really struggle. And I don't know as if I have great insight on, there's no right or wrong here because nobody can agree, Pastor Tim. Do you have any further comment on that? Have you been put in that position, I guess, of counseling?
No, only just thinking that still a little haunted by the prevalence of the percentage of girls understanding themselves to be male since the advent and spread of iPhones and social media.
Yeah.
And how much that may have been reinforcing something that, in a magnified sense, that may have been there to whatever extent it was, but then maybe magnified just because of all the peer pressure.
Yeah, and we'll be talking soon about how the general trend worldwide, so this isn't just a Maha thing, the worldwide trend is pulling back on how aggressively we move forward on gender affirming care, medical and surgical treatments. Worldwide, everyone is taking a breath right now. And I'll share some of that. So things have shifted in a sort of halting direction, which some groups, like the Trevor Project and WPATH, which we're going to talk about, have concerns about, since they're generally pro-gender affirming care advocates.
I have a question about how did HIV affect our acceptance of people that identify as change their sex or their gender or whatever? How did HIV, do you think HIV and what happened then was has been an effect on this?
It created a worldwide panic, didn't it? Initial HIV infection rates were higher in gay men, and it created an instant association of that virus with gay men that I do think lingered. I haven't done much specific reading about that, but I think it added over the years to associating HIV to certain populations unfairly because it affected all kinds of different populations.
Well, I think it affected the acceptance
Okay.
of a lot of these people. I was a member of the Lutheran Church in Aurora, and there was a family there. The husband thought one way, and the mother thought another way, his wife. Two out of the three, they had 3 boys. 2 out of the 3 boys became, one of them died of HIV, and another one, associated with guys and so forth. So it actually tore that family apart because the husband and wife saw things differently. And different support. The mother supported them, the father didn't. But I just feel that HIV affected the acceptance of these people and drove a lot of behavior, acceptance, and it's kind of sad because this one boy that died of HIV, he was a nice guy. I liked him, liked being around him.
Mm-hmm.
But
yeah, it was a public health crisis that, fortunately, huge amounts of research. This was a success story because it's a well-managed condition now. But it was certainly dominant in my childhood, growing up in the 80s and 90s. It was a dominant part of our national conversation. So, well, thank you for the thoughts. We were talking about family. Let me find where we were here. The 8.4 times, let's reiterate that. That's a very concerning statistic. So perfection is not required. This is key. The research is clear. A parent does not have to be ideologically aligned to be life-saving. A parent doesn't even need to believe the child's identity to engage in supportive behaviors. Asking the child how they're doing, standing up for them when others mistreat them, and allowing them to participate in activities that they find are enjoyable and even protective, even if the parent remains skeptical. These are important things. I found one resource that parents can even admit they don't understand, but assuring your child that they're loved and protected above all else appears to carry great power. Youth outcomes tend to be tied to perceived support rather than their parents' private theological or ethical stance. So parents can be scared, they can be ethically conflicted, but they don't have to change all their thoughts or theology overnight to help their child. They just have to be that source of safety. And parents do very much grieve sometimes over the child they thought they had, and it's an adjustment to change how they see their child.
I think this whole issue, it's as tough on the parents as it is on the child. The parents, I think, probably feel embarrassed.
They can?
I don't know if there's support groups for parents or not,
Yeah.
but the parents are really affected too by.
Yeah, well, I don't want to minimize what the young person's going through as sort of can be quite horrific for them. But yeah, it's a family systems issue. And that's why I mentioned I can empathize with parents. If I were in that position, I don't know how gracefully I would have handled it. Worse, yeah, Lynn says it's definitely worse for the child, and I think we should keep that in mind.
When you give counseling or help youth, do you also talk with the parents?
Yes, all the time.
Okay.
Yeah, exactly. And so that's where I hear a lot of this doubt and hesitation. And I try to empathize with them, because trying to bully them into here's what you need to do, that's not going to be helpful. It's not going to bring about change. Helping them feel heard and understood, and then sort of walking through what their child most needs right now is just to hear, I love you. That's the minimum. Let's get that going. And so many families struggle with that.
Well, I think that's about what RIC is all about too.
Yeah.
Support.
RIC is about love and support. Well said.
Eric, sorry, I have a question.
Chris.
So what I'm seeing throughout this, combined with this and Clay's presentation, is that supportive family, friends, peers, church, organizations are what really dig into that percentage of youth who have suicidal ideations, depression, that sort of thing. And I know you said there's not a great amount of data that's reliable, but is your instinct that those things are cumulative?
Yes.
Okay.
If I'm understanding your question,
Like,
is
just say, for example, if you have a really supportive family and that knocks it down 10%, well, then does it go down even further, the more support?
absolutely,
Okay.
yeah. One supportive adult is sort of what we see as the minimum for a reduction of risk, but a whole community of support, absolutely. If you could approach, if the LGBTQ plus child's neurological system can support sort of a baseline level of hypervigilance, that we'd like to think any of our teenagers would be comfortable walking into church. Well, some might not, but if they are completely comfortable and they're sort of just free to be a teenager, that would be the goal. Because then, in theory, the risk would be at baseline. Good question. Yes? Yeah. Yeah. Clay's going to hold me to that one. Clay wants to talk about persistence or desistance. In the interest of time, I was going to sneak ahead, and because it's a paragraph that I don't know if I have a good firm handle on, but Clay wants it, Clay's going to get it. A major 2022 study followed youth who had socially transitioned. I don't know. These are adolescents, I will say that. 5 years later, 94% still identified as transgender. And we're going to talk a little more about what's called desistance, but right now the point would be the counsel for parents is even if you think, even if you believe, even if you pray your child's going to be that 6% who desists or detransitions, the best clinical outcome, regardless of which camp your child is in, is to be that supportive person. Because you want to know that you want them to know they can trust you and be safe with you. If they eventually decide that they are a cisgender person, they'll come to you and tell you that because you didn't make them feel like a failure. Does the support affect the rate? No. Does the? Yeah, Clay's question is: does the level of parental support affect the rates of persistence or desistance, the number of kids who remain transgender versus the number of kids who ultimately say, I'm a cisgender person? No. And we'll talk a little more about that. Was that consistent with what you saw when you looked into it?
I think so. One of the things that I saw was earlier age. I did find data from kids in more of that 3 to 12 range.
Yes.
That rates of desistance are actually quite high. Like even the majority of kids
Yep.
who, and it's weird to even talk about like gender identity at that age because they don't even know gender, right? They're just learning all this stuff. But it's very common that they are
fluid at that point
Yes.
because they haven't done all of the work they need to do to figure out who they are.
That's right.
And so those desistance rates at those ages are quite high, like 50 to 70%. But as you said earlier and reiterate here, once they get to adolescence, they're quite stable.
Yes.
And I just think that point that parental support doesn't affect persistence, desistance is critical because parents might be concerned, like, what if this is a phase and if I support it,
Thank you.
I somehow reinforce it and they stick in that?
Yeah.
And no, if you support it, you're just going to make them safer and feel loved.
Thank you, yes.
But they're going to figure out who they are one way or the other, whether you support them or not.
This is true teamwork. Clay helped me put into words what I wasn't doing. Thank you, Clay. Yes, parents need not fear that by supporting their child, they're making this stick. The child's going to be who they are, right? You're not making that happen. And so we'll talk, treatment is informed, and my next few slides are treatment, is informed by the fact that the rate of desistance or detransitioning amongst young children, pre-puberty children who say their gender doesn't align with their sex, those rates of desistance are very high. If it persists into adolescence, into puberty, that tends to be a very firm thing. And so that's why treatment recommendations for the two groups are very different. In terms of psychiatric diagnosis, just a few notes that aren't terribly important for this talk. We use the Diagnostic and Statistical Manual of Mental Disorders. This is the worldwide gold standard used by the majority of worldwide mental health clinicians, psychiatrists, psychologists, therapists. I'll be glad, this is my copy, I'll pass it around. I did mark the page, we're going to talk a little bit about gender dysphoria, and I marked that page. If anybody wants to read it, you're welcome to pass that around. It is a proprietary book. I kind of had to memorize that at one point, but correct. It used to be DSM-3. I trained under DSM-4, and now it's DSM-5. So myth number one, being transgender is a mental illness. Pretty easy. You all know the answer, right? No, there is no psychiatric diagnosis regarding a person's sexual preference or gender identity. Much like medicine, mental health or psychiatry has some regrettable past. The first DSM back in the 60s, homosexuality was a mental health condition until 1973. Gender identity disorder, when I trained in the early 2000s, was a mental health condition. Gender identity disorder until 2013. And now gender dysphoria is the diagnosis. Gender dysphoria doesn't refer to the fact that a person is transgender. It refers to the fact that that's a condition that leads to psychological distress. The mismatch between how I am in my brain towards how I present myself to the world. You can be transgender without having gender dysphoria too. I don't know if I see it that often. Most young people who are non-binary or transgender struggle. It's hard for them. So the World Health Organization uses different classifications, and they have this ICD code, but they have a similar condition, but theirs is called gender incongruence. It's not a disorder, but it's a label for a marked persistent mismatch between an individual's experienced gender and assigned sex. In 2019, they moved it from the section on mental disorders. Now it's in the conditions related to sexual health. I don't know if that's the best chapter for it either. We don't use World Health Organization ICD codes that much in psychiatry, so I don't think about it too much. So in psychiatry, we have a lot of diagnostic challenges. Gender dysphoria is based solely on subjective report, what a person tells me. This isn't the only diagnosis in psychiatry like that, of course. Our federal government, the Department of Health and Human Services, they recently wrote a report we'll talk a little bit about soon, but the following paragraph I'll read. Health authorities have also recognized the exceptional nature of this area of medicine. That exceptionalism is due to a convergence of factors. One is that the diagnosis of gender dysphoria is based entirely on subjective self-reports and behavioral observations without any objective physical, imaging, or laboratory markers. The diagnosis centers on attitudes, feelings, and behaviors that are known to fluctuate during adolescence. I can't argue or disagree with those statements. That's all accurate. The rest of the report is a bit rough. We'll talk a bit about it, but I can't argue with that. So how do we identify gender dysphoria and distinguish it from other mental health conditions? In psychiatry, we have what's called the differential diagnosis. You list all the things it could be and why it's one thing and not another, and that's where I guess you use your knowledge and training. The differential diagnosis, based on what a person tells me about their gender, can be huge. Psychotic disorders, body dysmorphic disorder, trauma or PTSD, post-traumatic stress disorder, eating disorders, medical conditions. Clay talked about intersex, disorders of sexual development, neurodivergence such as autism, where gender diversity is more common. But to make things more challenging, these things can all coexist. They can be there along with gender dysphoria. There's also times we'll counsel families and parents, a young male who prefers traditional feminine behaviors or vice versa, that may not be a disorder at all. We also need to screen for substance use disorders because it is at a higher frequency in LGBTQ plus youth. So in child and adolescent psychiatry, we try to not just make a label, but build what we call a case formulation. We look at not just what the young person's experiencing, but also why it's happening and why at that time. There's biological factors, their sleep, their appetite, their energy, their family history, their substance use. Psychological factors like thought patterns and coping skills and self-image. And then of course the huge social section, family dynamics, school and peer dynamics, and community belonging. Add to that, sometimes we feel a need to rule out biological illnesses like autoimmune diseases, vitamin or nutritional deficiencies, thyroid disease, anemia, diabetes, I could go on. But our important job is also to help families distinguish between normal development. As Clay mentioned, if I'm seeing a 7-year-old who's exploring their identity, that's a normal part of childhood. If it's a 15-year-old who says, this is who I am, then we also need to consider that a little more firmly. The treatment toolkit. Thank you for your patience. We are making progress. Everyone doing okay? Anybody need to stand and take a break? Anything like that? Have John tell a joke? Psychotherapy is the absolute foundation here for gender dysphoria. There's a few different brands of psychotherapy which are most commonly used. Some of you may have heard of cognitive behavioral therapy, DBT or dialectical behavioral therapy for different reasons, used for different reasons. We do use medications when symptoms are so severe that the child cannot engage in normal therapy or life. There are no FDA-approved medicines for gender dysphoria. There are FDA-approved medicines for major depressive disorder, which is commonly comorbid with gender dysphoria. Treatment is more than just fixing what's wrong. It's helping that young person build those psychological reserves so they can thrive in the face of stress in the future, also known as resilience. We're going to talk about resilience. Gender-affirming care standards require that thorough assessment for different co-occurring mental health issues. The concept of watchful waiting. It's the concept of giving young people time and space to figure out things, and they will. Many of these young people will continue to identify as, say, transgender, and some will not. What adolescent does have their identity completely figured out? It's an intensely uncomfortable time. We know this. So clinical care for gender dysphoria is slow. It's multidisciplinary. It's focused on the whole child. It involves pediatricians, mental health professionals, endocrinologists, families working together. The first steps are not hormones or surgery. That's another important take-home point to counter the panic. I'm afraid, I'm going to give away the answers. I was going to quiz you all here. But since it didn't animate, we're going to go through the consensus. And by say consensus, is it unanimous? Does everyone agree? No. But the general consensus on these different kinds of quote-unquote treatments is as follows. If I weren't giving you the answers with check marks and X boxes, Would you say using a young person's preferred names and preferred pronouns is a pretty accepted treatment? Yeah, you're going to say thumbs up to that, and you're right. Other social transitioning, letting them do the hair they want and the clothing they want, is that pretty accepted? Absolutely. Who's heard of conversion therapies? Besides Pastor Tim, Lisa, you've all heard of this, okay. A few thoughts on conversion therapy, but it's been in the news lately. Supreme Court ruling gave, was it Colorado, a therapist freedom of speech to conduct essentially what is conversion therapy. Also known as reparative therapy, they're intended to change a person's sexual preference or gender expression. These are discredited, they're harmful, they shouldn't be done. There's no professional mental health organization of repute that would support them. I don't know if it's legal or not. It doesn't get done that I hear. Those people don't come to mainstream psychiatrists or psychologists. We don't see them. So I've never seen people that have had conversion therapy attempts. So I'm not afraid, I don't even know.
So just to,
Chris, our lawyer might know.
I don't know about Iowa, but in the case of Colorado, when a case makes it to the Supreme Court, it's generally because the state or city or whatever has passed a law saying you can't do this. And then somebody's like, this violates my long list of rights.
Mm-hmm.
In this case, I would like to take the unwise step of converting children based on any number of shameful theories. And I can do so because it's First Amendment right. Anyway, so I don't know about freedom of speech, right? So I don't think, and I could be wrong, that there's anything either way in Iowa, but I don't think any of us in here thinks that the state of Iowa is going to pass a law banning conversion therapy anytime soon. Right.
No chance of that happening.
No.
And you're probably right. In the current culture, I don't think it's common in Iowa, but maybe I'm clueless. Yeah, I mean, they tend to be a more of a fundamentalist church. It's not just Christianity, Muslim faith, Christian church that Lynn's aware of, okay. Yeah, well, they're not recommended. Clay, shout and I'll repeat it, or do you have a mic?
So, I don't know if you guys are aware of Sarah McBride. She is a transgendered representative. I can't remember what state. Anyone remember what state she represents? Virginia. Delaware, okay. So I actually heard her speaking recently on the Supreme Court decision, and she had an interesting take on it, which is that we need to, like as a priority, we need to think that healthcare decisions need to be made by the individual, their family, and their healthcare provider. And while we might disagree with things like conversion therapy, and the medical community definitely disagrees with it, passing laws that ban it can be tricky, because if we do that, then the other side, for example, could pass a law banning gender-affirming care. And so it might be a good general approach to say we shouldn't ban any type of therapy, because that could potentially get in the way of the individual, their family, and their healthcare provider making the best decisions for that person. Now, what's tricky is that, is it freedom of speech, or is it following evidence-based recommendations for what is healthiest? And so it might be one of those situations where it's not necessarily ideal, but it might be more problematic to fight it than it is to...
That's an insight I hadn't thought of, but I appreciate. Because the freedom of speech argument, without being a legal scholar, feels to me like, freedom of speech applies if you're not negatively affecting somebody else with that freedom of speech. And there's pretty good evidence that reparative therapy increases depression, anxiety, suicidality. But the more well, it passed it removed them from legal protections. How you interpret that, I'll leave it removed them from the class of, is that correct, civil rights protections.
And getting care.
It removed gender identity.
Thank you.
From
As-
the Civil Rights Act, from the Iowa Civil Rights Code. There's a list of, gender, ethnicity, all that kind of stuff that's protected. And gender identity was in there. Then Iowa became the first state to pull something out of their civil rights code and say this is no longer a civil right. Iowa's first. Great.
So wrong.
So it wasn't necessarily passing a law saying outright
Right.
everybody's permitted to, but I mean, it had the same effect. Discrimination in areas of employment, housing
Hotels,
is now legal.
care.
Yep.
Yeah. Okay, let's get back to what's the consensus? Conversion therapies, no. The consensus is that's not a recommended treatment. Psychotherapy, commonly known as therapy or counseling. Yes, the risks are pretty low. Not completely without risks, but for the most part, very little risk to psychotherapy with a lot of potential benefit. It's an evidence-based part of treatment. Psychiatric medications, when appropriate, for treatable comorbid conditions. Yeah, that's an accepted part of care, when appropriate. Not just handed out for gender dysphoria because it won't affect the condition. Medicine and surgery for pre-pubertal children. No, in general, this is not recommended, and in general, it's not done. Nearly all professional societies agree that this kind of treatment is not ethically appropriate at a young age. The care at that age is 100% social. Pronouns, names, hair, things like that, support. And then to give away the answer to medicine, puberty blockers, hormones, and surgery for adolescents, mixed bag. By far the most controversial, and that's where we're going next. Like many socially progressive things, the Dutch were the first to provide medical gender-affirming care in the 90s. In the 2010s, this is where that World Professional Association for Transgender Health, WPATH, I'll call it, and Endocrine Society published their standards of care, and this became the gold standard guide for providing gender-affirming care to young people. Treatment with medications. So in medicine, we always weigh the known side effects of an intervention or giving a medicine against the known high-risk outcomes as if you don't do anything. In other words, in this case, untreated severe distress or dysphoria. So use of puberty blockers and hormones is quite controversial, as you all know. Puberty blocking drugs are said to provide a timeout and put a temporary pause on puberty. May not be that quite straightforward. This is controversial. They stop the signal from the brain to the body to produce the sex hormones that Clay taught us about, estrogen or testosterone. The intention is to alleviate the distress of a pubescent child's secondary sexual characteristics developing when it doesn't align with their identity. Critics to this believe we don't have enough evidence of long-term effects of halting puberty. Possible long-term impacts that are described including concerns about future fertility, bone density, neurodevelopment, growth spurts. Again, WPATH and Endocrine Society have been the gold standard guide, and they do have guidelines for when puberty blockers should be used. Not immediately, but they are recommending, and they still recommend, despite shifting culture, use when appropriate. My professional societies, American Academy of Child and Adolescent Psychiatry, American Psychiatric Association, and then our colleagues at the American Academy of Pediatrics typically defer to WPATH and Endocrine Society when it comes to our recommendations. In 2023, Iowa passed Senate File 538, which prohibited, absolutely prohibited, physicians from providing puberty blockers, hormone therapy, or surgeries to anyone under 18 in Iowa. Black and white, it's done. So for the last couple of years, it has been illegal in Iowa to do medicines and surgery for minors. Now more than half the states have similar laws. Between 2020 and 2024, this shift that I speak of has been happening in several European countries, and these are historically progressive countries. Finland, Sweden, Norway, United Kingdom have shifted back to a more cautious approach from where they were between 2015 and 2020. They haven't outright, in general, banned medicines and surgery, but they definitely are prioritizing the psychological support over the puberty blockers. The famous report out of the UK, Dr. Cass, the Cass report, was one of several papers which has informed a lot of the decisions being made in these European countries. So I think it's important we all know it's not just this administration in America, it's not just MAHA, it's a worldwide trend right now to slow down a little bit because of all we don't know. A year, Fred? Do the parents have a what?
Final say. Do the parents have a final say?
I can only say in the United States, I can't provide any kind of treatment to a minor without parental consent. There are some protected types of treatments, substance abuse treatment, reproductive health, like birth control. Fred, I will admit, since I don't actively prescribe hormones or hormone blockers, I don't know if that in the past was ever circumvented, if that was a type of treatment that could be done without parental support. In general, parents have the final say.
Turn it on. Okay. I may not have understood this correctly, but I thought I read that the Dutch protocol, which was one of the four founding recommendation about how to help provide treatment for transgendered individuals, it was really based, their subject base, all adolescent boys, no girls. So their treatment protocol was based upon applying these treatments to boys only.
Okay.
And then when it went wide beyond the original setting where the data was collected, it started being used for both girls and boys indiscriminately. Have you heard that?
No.
No, okay. I heard that was part of why there's so much pushback, because it started being used for both boys and girls, and there was not.
And I don't know if the originally was done specifically targeting the focus of the treatment biological males, but that was historically the vast majority of transgender patients were biological males. But no, I don't know. It's an interesting point. I probably would need to know more about that. I'm not sure. Okay. Must have been true, right? I am caught up on my slides. So my last line on here, so in January 2025, about 15 months ago, what I will call a provocatively titled executive order, protecting children from chemical and surgical mutilation. This was issued under this administration, and it halted federal funding to anything related to gender-affirming care, medical and surgical gender-affirming care. And it tasked the Department of Health and Human Services with writing evidence-based treatment guidelines. And this was published in November. HHS published the Treatment for Pediatric Gender Dysphoria. That's available online. It's an interesting document. I just read the executive summary. I did not read the all 120 pages. It's a fairly blunt document which called out, you've heard this from Clay and now me as well, accurately so, a lack of rigorous evidence-based data to support certain types of gender-affirming care. And that has really cemented in this country this pullback in how aggressively treatments are offered. Definitely aren't going to read some of those fonts. Kristen,
Can I ask?
you're all very active. I do
Okay,
appreciate
thank
that.
you. I'm sorry. But it just seems convenient to me to take a field where we currently don't have a lot of, what did you call it? You had low
Low-quality evidence.
quality evidence. And in that case, generally in the medical field, you keep gathering evidence to try and improve the quality, not to meet a desired outcome, but to discover, find out. And in this case, it seems like they're saying, we're going to use the fact that there's low quality data to prohibit you from gathering more data.
At least federally funded, yeah. And in medicine, data is either gathered with federal funding or with pharma, and there's no pharma funding for this because there's no medication support. So you might be right, Kristen. Has this halted research? We do have European research happening, and that could give us hope because, yeah, we need to improve our knowledge of this area. So fair observation. Advocacy groups, if they can fund it, that would be a good source too. Let's get through surgery fairly quickly. Are we doing okay on time? We're at 8. Should I just keep rolling? Good, okay, we'll keep going. WPATH, again, was the gold standard in guidelines for gender-affirming care surgery, which of course is even more controversial. Prior to the recent trends I've discussed, which have reined things into a more conservative approach, surgeries for minors were still very rare, almost exclusively limited to top surgery, which is masculine chest reconstruction for older adolescents. The best numbers I could find, in 2022, the Journal of American Medical Association estimated that for minors 13 to 17 in the US between 2016 and 2019, a total of about 1,100 surgeries. And by 2023 to 2024, some estimates were that this number had risen to 2,000 to 2,500 annual surgeries before the 2026 restrictions took hold, which I'm going to mention in a second. Bottom surgeries or genital surgeries have always been quite rare for minors. Most major children's hospitals had internal policies requiring patients to be 18 for genital surgeries, long before more recent formal recommendations. A 2023 analysis of insurance claims found that genital surgeries in minors were, quote, statistically negligible, likely numbering in the low dozens nationwide per year, usually for older teens 17 and older with years of gender dysphoria. So, myth, children and adolescents are rushed into mutilating surgeries. No, gender-affirming surgery is rare in minors. I don't know as if we can ever say absolute zero to anything, but essentially zero in pre-pubertal children. However, in February 2026, this just happened, the American Society of Plastic Surgeons, these are the folks who would be doing these surgeries, published a very, it was a mic drop moment, a significant position statement. They quoted the Department of Health and Human Services report that the natural course of pediatric gender dysphoria remains poorly understood. In small print, it talks about, I'm just going to read it a little bit. Available evidence suggests that a substantial proportion of children with prepubertal onset gender dysphoria experience resolution or significant reduction in distress by the time they reach adulthood. That is what the numbers tell us, that children they might shift at a higher rate. Evidence regarding adolescent onset presentation, which has become increasingly common since the mid-2010s, is more limited, but similarly does not allow for confident prediction of long-term trajectories. Importantly, clinicians, even those with extensive experience, currently lack reliable methods to distinguish those whose distress will persist from those whose distress will remit. The HHS report underscores that this uncertainty has significant ethical implications when the likelihood of spontaneous resolution is unknown and when irreversible interventions carry known and plausible risks. Adhering to the medical principles of beneficence, doing well for others, and non-maleficence, not doing harm, requires a precautionary approach. The American Society of Plastic Surgeons recommends that surgeons delay gender-related breast, chest, genital, and facial surgery until a patient is at least 19 years old. So this position statement doesn't mean that surgeons can't provide the care they think is appropriate. Most physicians stay within the boundaries set by their professional societies. If you go outside those boundaries, you're exposing yourself to all kinds of potential problems. So essentially, this is saying there will be no more surgeries for minors or even 18-year-olds at this point. That's a big shift. Quality of evidence. We've talked about this several times. Randomized controlled trials are the gold standard. Clay mentioned, and I have the same comments, it would be unethical to conduct a randomized controlled trial when you are causing potential or probable harm to the control group, the group not getting treatment. Adolescents suffering from suicidal ideation cannot ethically be put in a no treatment group. Add to that the challenge of trying to assign a blinded placebo when you're prescribing a hormone, for instance. It's going to be rather obvious if you're getting a placebo or the treatment. Unlike a blood pressure randomization, if you're told to not check your blood pressure, you probably won't know if your blood pressure is in a better spot with or without the treatment. So the CAS report I mentioned out of UK highlighted the low certainty of the evidence. Without a randomized controlled trial, it's difficult to prove that the treatments being delivered are the cause of the improvement, not the increased therapy, not the social support that comes with the visits as part of a research project. Another quote from the CAS report is remarkably weak evidence. So it was pretty scathing as well. A quick note on pathways. The UK is currently, has a pretty major research project, which I think is the first randomized controlled trial in the field. It will explore the effects of puberty blockers in transgender adolescents, tracking physical, social, emotional well-being in groups that start puberty blockers right away versus not a placebo, but a delay group. You're going to spend a year not getting puberty blockers, and we're going to compare the outcome of starting puberty blockers now versus starting puberty blockers a year from now in a randomized fashion. So this could be a very important study. WPATH, which I've mentioned several times, has advocated for active treatment. They have expressed concerns about this study, the delay group, not getting the care they think is appropriate. I want to reiterate the guardrails of gender-affirming care. No one acts alone. Treatment plans are individualized. There's no rubber stamp, but it's multiple specialties involved, and it's just a myth that solitary physicians are blazing ahead and providing treatment. The answers are up there. True or false? Most people who transition eventually regret it. The data is pretty clear false. Gender identity can change, especially amongst kids. But for those who persist in gender identity disorder, in being transgender, and proceed with transitioning, and that's not specifically defined here, don't eventually regret it. Regret rates for gender-affirming care are rather quite low, less than 1%, which surprised me. I would have thought higher. In contrast, the regret rate for knee replacements is about 20%. So this regret rate, it's different from rates of detransitioners because external factors apply to detransitioning. Most detransitioners realize they weren't actually trans. That's actually false. People detransition for lots of reasons. but more often than not, it's because of external factors like financial, family pressures, family rejection, safety concerns, and not because they changed their identity. The recent HHS report, which I encourage you to go read, did say, quote, most cases will remit, but they were talking about the childhood sample. Again, adolescents who persist in gender dysphoria and transgender identification, it tends to persist, which is why with young people, the treatment is that watchful waiting, the conservative approaches. So you might see conflicting headlines. One says kids will grow out of it, and another saying transition is permanent. Both can be true depending on the age of the child. In the interest of time, I won't spend too much time talking about resilience other than we all need it. We want to build it in young people. I like this quote, resilience is the immune system of the soul. I didn't write it, but it's attributed to multiple different types of persons and professionals. Resilience is not innate necessarily. We have to help people build it and grow in it. That's an important thing. Let's move on to an interactive slide. So ethical dilemmas. These are situations I thought of, I wrote, which may or may not have happened. I'm not going to tell you. I'm not going to tell you how I handle it. But I'm curious what your thoughts are. First one, adolescent on hormones now declared illegal. Say you're the attending psychiatrist at the hospital and a patient who's, we'll say, a month shy of their 18th birthday. They're a minor, but they're real close to adulthood. They're admitted to the hospital. They are on hormone therapy, which is now illegal in Iowa. They drive to another state. They get it filled in another state. And then they drive home and they take their monthly prescription. But when they're in the hospital in Iowa, the only way you can take a pill in a hospital is if a doctor writes it. I don't care if it's a Tylenol. The doctor has to write it, or the nurse practitioner, in my team's case. What do you do as the physician if that child gets admitted? If they don't take their medicine, I worry about negative physiological or physical and psychological effects. If I prescribe it, I'm breaking the law and jeopardizing my medical license. Comments? Thoughts? Does it feel like an impossible situation? Can't do a lateral transfer. Insurance won't pay for that. Can't transfer. That's a great idea, but nope. How long is the hospitalization? That's a fair question. How long is the hospitalization? And that's very relevant here. For better or worse, hospitalizations are extremely short these days. In the old days, mental health hospitalizations were a month, 3 weeks, 6 weeks, something like that. Average length of stay on adolescent units these days is 4 to 6 days. That's about how long we get to fix everything. So, point well taken. In 4 days, will not taking that medicine cause major problems? Maybe not. Maybe. You don't have solutions, do you? My only comment is this is maybe what happens when politicians enter the arena. Unintended consequences to laws. Again, whether this happened or not is irrelevant. Could happen, and I don't know what I would do. And then if you're thinking, well, that person is almost 18, just write the order. What if they were 13? Does that change anything? I don't have an answer there. I don't expect you to have one. This one maybe isn't really an ethical dilemma. It maybe is more straightforward to some of you, maybe not for all of you. What if you have a patient who says, yes, my chart says I'm a male, but I want you to use she and her pronouns. Is that a problem with anybody? If it was for me at one point, yeah, I got over it long ago. It's really not a big deal, I think. So that one's pretty straightforward. Doesn't matter if they're 17 or if they're 8. Might be a difference, maybe not. Here's another one I got over long ago. What if their pronouns are they, them? That's extremely common. Extremely common. It does create some misunderstanding in medical charting, but you get over it. That one's pretty minor, I think, too. Here's where it gets interesting. What if the young person wants a pronoun used that I have a problem with? What if their pronoun is it? They're depressed, they're demoralized, they hate themselves, and their pronoun is it. I want to respect them and honor them, but am I contributing to their state of misery about themselves? It's about all you can do, I think, is talk and say, hey, here's why I don't think that's great for you. Can we talk about that? Yeah, I'm not comfortable with it. I'll tell you that answer. Okay, maybe easy. What if the patient whose name is Eric says, I want you to call me, pick a name typical associated with a girl. Is that a problem? Yeah, the charting. Modern healthcare charting has a space for preferred names now. It's better, but it does create dilemmas if the name in the chart doesn't match the name. Absolutely. But yeah, most people would say, yeah, call people what they want, right? That's not a problem. Another fun one. What if the name they tell me they want to be called, again, like the pronoun, I'm not comfortable with? What if it's Zero is the name they want to be called? Chris said, ooh, yep. And they're here because they hate themselves and want it in their life. Or maybe it's my personal Christian beliefs. What if they want to be called Satan? I don't like that. So there are some serious dilemmas here. This is extremely common. What if when I call the parents, Fred said, do you involve the parents in the treatment planning? Always. I have to. And 90% of the time, it's very appropriate to do so. What if I call for that informed consent and I use that name and that pronoun that child wants, and the parent said, slow down. That's not the name I gave my child. Happens more often than, it happens a lot. That's quite a thing to navigate, to tell a parent, I appreciate this is not what you're used to, but this is what your child's asking for, and our evidence is this is the best care. And
do you ever, when you're in the presence of the child, do you use the name that they prefer? But when you're talking to the parents alone, do you use the name that the parents prefer?
all the time.
Oh.
Yes. Especially the next one. A lot of times young people tell us who they are, but they're not out to their parents. So we have to sort of dance that step of not screwing up when we talk to the parents, protecting that child's privacy. They're not ready to be out to their parents, maybe because they know how it will go. Yeah, all the time. But what if the parent then accesses my chart and sees what we're calling their child and then calls and yells at us? They can. Yep, they can access their minor's chart. So there's not easy answers here, folks. This is just a collection of what I consider the most common ethical dilemmas. Some of them maybe didn't happen. Okay, you've done great hanging with me. Thank you. A few concluding thoughts. I think you've heard many times tonight, and I hope you remember, community provides better medicine than any doctor or therapist for a lot of these situations. Listen without judgment, listen with compassion, foster belonging, recognizing that silence can be perceived as threatening. Calling out discrimination when you see it, use correct names and pronouns. Again, research shows that one accepting adult can significantly decrease risk. I have not said expert adult. I haven't said perfect adult. I haven't said gender specialist adult. I haven't even said agreeing adult, okay? When you act as that one adult, you're doing more than being kind. You're helping downregulate that child's nervous system. Our job in mental health isn't to pick a side here in this culture war. It's to hold the tension between the reality of these youth are at higher risk for mental health difficulty and suicide, and our medical evidence for how to best help them is still evolving. So while this talk isn't about my opinions, and an RIC vote is not about mine, I'm going to use my personal privilege as your speaker to share that I have learned in this. My personal evolution has been, I think when I first talked to John about RIC, my first thought was, well, isn't everyone as welcome enough? I think a lot of people probably feel that way. I think Nothing about RIC is that we lose our own moral or common sense boundaries. We get to keep those. We're still allowed to exercise discernment, but I do have a better personal appreciation for why an explicit statement of welcome might be important. Several times tonight I mentioned that silence can be perceived as rejection. And so I now have a better understanding that being quietly supportive may not be enough, and that an explicit statement of welcoming and acting on it would be important. So I loved how Clay ended his, and I have a similar thought. Even if I doubt when I meet a child that the long-term permanency of their gender identity, even if I don't understand it, it goes a long way to let them know I value them as a person and want them to experience peace. It is not hard to do. So I don't personally want to be part of any group that is a risk factor. To make a young person feel unloved or unwelcome. So if we have the opportunity to be a protective factor, I'm all in. Thank you. You were a good audience. Well, thanks, Fred. I'm happy. I'm not in a hurry, so I'm happy if people want to share more thoughts. I don't always have perfect answers, but or if you have questions, let's do it. Clay?
So this isn't really a question for you, more just for the whole group. It's really struck me, that idea that being neutral can be a risk factor, being silent can be a risk factor. I think it was Pastor Katie who maybe mentioned this when she was here, that she knew some youth who were LGBTQ who felt like the environment here was negative, not because it was overtly negative, but because it was silent or neutral. And so I'm just wondering, beyond like explicit statements, which seem potentially hollow, like what can we do as a congregation to make it clear that we are supportive and not just tolerant?
I won't speak for the RIC committee. I think they would say that meeting the RIC expectations would be the bare minimum. Yes, that's just the start. And then beyond that, what we can do, I'm going to ask them for if they have any dreams for what we could do as a congregation. If we become an RIC body, what's next?
A couple little things is on our name tags, we could put on our pronouns. So if everybody has their pronouns, then if somebody has specific pronouns, they'll feel like they're just part of the group.
I think it'll be important for us as a congregation to maybe not as intensely as we have, with the time limit constraints that we have, but to continue to have events like this. It's a learning process. There's no end. And so I think that shows that as a congregation, we're thoughtful, we're intentional, we're discerning, and it's all under an umbrella of faith. There's a lot of really loud faith voices that adamantly reject the LGBTQ community. I think it's a challenge right now for other faith voices to be equally loud as almost radically accepting and affirming. And when I say radical, I say it in a sense of Jesus being radical for his time, not burn down buildings kind of radical. But I think that's something as a congregation that would make us continuously more rigorous in our knowledge and our skill of being affirming.
Another small thing that we can do that I've been trying to do is when I see someone that I perceive to be from a marginalized group, I purposely go up to them and welcome them to our church and thank them for choosing to come to this worship service, because that means a lot to me that they took the risk to walk in our doors. On Easter Sunday, there was a biracial family here, and I purposely went up to them and said, "You are welcome here. I'm so glad you chose to be here with us today and your beautiful family." So those are little steps that we can do right now.
It's Doubting Thomas Sunday. We can celebrate uncertainty.
Little preview there.
Here, hon. It is on. One of the things I just want to mention is that the effort and the work that we were doing for the Reconciling in Christ team, exploring this journey about what it might mean to be more welcoming, inclusive, and affirming, this really is the very beginning. I mean, and our challenge will be to figure out how to live it out and what we can choose to do as a congregation to live out this dream of ours. And the entire congregation needs to be part of or be available to have part in that conversation to figure out what feels best for our community. Because not everybody is going to be in it the same, have the same perspective.
Right.
And we need to honor everybody and where they are, affirm them in their beliefs, wherever they are. And that will be the challenge because we are not all of the same mind.
It's on.
The civil rights movement is a prime example. It's been taking years and years, and we're still not there. And so the civil rights movement, I think, is a prime example of how much time it takes, and you will never get there because people are people. But we could try.
It's good to have aspirations, yes. Other questions, comments, complaints? Clay's
Your suggestion earlier, Eric, was listen.
I do have another question, though. I'm sorry, did I butt in front of you?
Eric's suggestion earlier was listen more than we talk.
Yeah.
The other question I have is about how to combat disinformation. Because like it seems obvious that you can't give your child, or you can't have your child, a teacher, a nurse cannot give a child an ibuprofen in school. Clearly they're not doing surgeries in school. It seems obvious, and yet that disinformation is out there and people believe it. And do you have a sense, coming from the medical community, is there an effective way to combat that disinformation? Because I think when people learn like how rare these things are, it's eye-opening. But I don't think most people would believe, like if we posted on our Facebook page, like these things almost never happen. Like the surgeries, bottom surgeries in adolescents are in the dozens a year. And people would be like, no, you're lying. They're in the tens of thousands. So,
yeah, and I think what you highlighted is exactly the fact that I went through an educational process here. I didn't know how rare it was. I've heard stats that made me shocked and scared for kids. It requires that deep dive that people really don't take the time to do. So this group that collected tonight, a lot of you are already well on your journey into what you think about this process. I don't think we have too many dissenting voices tonight. It's being willing to learn and listen to multiple sources. I included alternate viewpoints down below because I think it's an important perspective to gain. Some of those have some reasonable things in there. The book Irreversible Damage, I sought Pastor Tim's counsel because I read it and I thought, what is going on here with young people and gender dysphoria and transgender? But I also can find multiple perspectives of how that investigative reporter used a lot of gotcha moments and took advantage of some stats in different ways. So I think I need to go back and reread it because I kind of got sucked into some of that hysteria that book includes. I have no magic other than providing calm and reflective communication, which the national scene does not do right now.
But when you have a president that comes out and says, your child gets on the bus in the morning as a boy, and he comes home at night as a girl.
I didn't know that. When Fred says people that are on the news every night say your child gets on the bus and is a different gender when they come home, yeah, that creates mass hysteria, doesn't it?
And people don't speak out against it. A lot of people don't speak out against it.
Yeah.
They think it's just a joke.
Yeah, calling out the nonsense when it happens needs to happen. Lisa?
I would I guess from my perspective, I give thanks for the people in this community, all that have presented, Eric, Clay, all the other members of the RIC leadership, who model learning as being willing to dig in and consider those diverse perspectives. And I think being a community that openly does that, that doesn't make a statement more, regardless of our beliefs, and I'm very guilty of this, like it's a duh moment, that shuts down conversation. And I'm very guilty of that at times. And so how can we have those kinds of conversations that say it's maybe our responsibility with the God-given brains that we've been given to dig into topics deeply?
I sometimes worry that my mind can switch so much on a topic, and maybe that's a healthy sign that we're willing to fight that internal discernment.
I'm wondering if maybe we should continue this conversation in the future. It's getting pretty late. Yes.
I don't want to go out in this.
So, thank you to Eric. Yes. And there are refreshments, so we can continue talking out there over a few bites to eat and something to drink. I haven't thanked this couple people yet, and they've been with us every single time, or with us. So Jeff Manthe and Mark Stern have been recording these sessions for us. And so Jeff's in the back room doing it. We don't see him, but he's there. And Mark Stern has also done that in the future. So thank you very much, Jeff and Mark, for doing this. And thank you all for coming. Appreciate it. So we're going to have, I think you're going to do an adult session this Sunday. So we'll have a little bit more time then. And then we'll also, next Thursday, we're going to show the video of this session for the people that can't make it tonight. So thank you very much.